My name is Dyfrig Ap Dafydd. I'm a GP in Llangefni and Anglesey. I've been a cluster lead in Anglesey and I'm now one of the primary care leads for the planned care programme. We're supporting the QI project partly because we've got quite a lot of experience of writing EMIS searches and templates and feel it'd be useful to have these and share these with everyone rather than everybody having to try and create their own, and everyone's skills are obviously quite different and it's nice to share where we can. The other reason we're involved is that we're supporting the implementation of the Community Health Pathways programme. This is a programme that's delivering pathways and guidance across a huge range of medical subjects across Wales. There's 500 and counting. The CKD pathway this year we feel is a very important pathway. It aligns with the QI, which feels nice and tied up. And part of the reason that both these things have been introduced is the big change in management in CKD, which is to encourage increased use of flozins in this group, regardless of whether they have diabetes or not. The evidence shows us that flozins massively reduce cardiovascular events, at least 25% by the looks of it, and reduce end-stage renal failure. So whilst they're very expensive, the cost is very outweighed by reductions in cardiovascular events and end-stage renal failure, and we want to be encouraging this. It's also part of this year's national prescribing indicators. So this is a useful project to take part in for various contractual reasons. Using the health pathways means that you can tick the box in the clinical governance practice self-assessment toolkits. It'll tick the boxes for the various contractual elements where we should be following guidance and showing that we're following guidance, and good for your appraisal because there's going to be a lot of audits and a lot of works for this, and it's meaningful work. This is a high risk group at high risk cardiovascular events, high risk of end-stage renal failure, and we can massively reduce that in this group. I think it's a project that is incredibly worthwhile and is a good example of something we should be able to deliver very well in primary care. These pathways are developed by national networks working with GPs at a national level, and that'll be GPs from across Wales. Once we have a national pathway that's agreed, these are localised to your area. Now, often the clinical advice will remain the same, but it's the knowing who to send, where and how. So if you've got particular local arrangements or numbers or emails or pathways for admissions or pathways for referrals in your locality, we want to make sure they're all here and very clear for you. I hate scrabbling around various websites, often finding the links are broken. I don't like relying on posters on the walls and pieces of paper in my drawers or emails that have been sent to me. I like that these are all in one place. They're going to be curated, edited, kept up to date. If people feedback a problem, that problem is corrected. I think it's a very worthwhile programme that should deliver higher quality and less variation across Wales. Now, we've already recorded videos on the various searches. This is video looking at the prompts and templates that are an offer for people if they want them. So there'll be another video on how to import those into your EMIS system if you want them, with this video to show how they work. So if I choose, for example, patients, if we're looking at patients who we might consider for flozins and CKD. So these patients here either have eGFR between 20 and 45 or eGFR 45 to 60 with diabetes or an ACR greater than 22.6. So this aligns with the QI and aligns with the pathway guidance in the community health pathways. It's worth noting that there's guidance on who might need ACE inhibitors, etc. And what we're looking at here then is the groups of patients who might well be eligible. We have already excluded patients who have type 1 diabetes or have a history of DKA or have had flozins before and it's been stopped, or that where there's an adverse code recorded. There isn't a code for flozins declined. If I choose an example patient from this list, when you open them up and if you have this protocol activated, it'll come up with a series of new prompts in your prompts box. This prompts box is in the top right of the screen because I have to hide the name. The screen is cut down so that you can't see any patient identifiable information. When you hover over any of these, it will tell you what these are for. So if I hover over the consider SGLT2 flows-ins, it tells me this person has an eGFR under 60 with type 2 diabetes, that they are diabetic with a Q risk likely over 10%. They also have an eGFR between 45 and 60 with an ACR greater than 22.6. So they're eligible for various reasons. There's a couple of other prompts. It's pointing out that some of these prompts are in your system already, but it's also pointing out that we could consider coding CKD, and that when you hover, it makes a suggestion as to coding. It says we should strongly consider a statin because their latest eGFR is under 60. We know that somebody with an eGFR under 60 has a high-risk cardiovascular disease. You don't need to Q-risk those patients. They should be on a statin, so it's suggesting we strongly consider that. And we've got a bit of an issue with people not coding annual reviews of diabetes. They'll often review the diabetics, but just not code. So there's prompts to say this person needs an annual review. You'll see here, this is a prompt that says assurance concern. Now, this relates to the assurance framework for diabetes, where it's looking to see, has this person had all 8 processes? If you hover over this, it'll tell you which processes are missing, which for this person is an HbA1c, UNEs, lipids, foot check, smoking, and BMI. So they really need to be brought in for review, but they're also in our consider flows in group. Now, if I double click on any of these prompts, it opens the template we've created. This is the cardio-renal metabolic template. The idea here is that it will align with the prompts. So it's pointing out this person should consider a statin because they've either got established cardiovascular disease, stroke, or eGFR under 60. Pointing out that they're diabetic with Q-risk greater than 10%. I'm happy with using Q-risk too, using the inbuilt calculators. Important to record family history whenever you're doing that, because family history has a significant effect on the Q-risk score. Their cholesterol is greater than 4, so we might want to consider more aggressive management. It gives suggestions on the coding for CKD. So this box where it says consider coding eGFR under 58, they have an age of ACR which is blank, which usually means that there was none recorded. So they, as in low ACR, it's worth pointing out that that may not show in some searches, because some searches are looking for an ACR that's over 0 and under 3. And of course, a lot of the labs don't just report with a comment rather than a number if the ACR is too low to record. Regardless, this person is just in G3A1 because their eGFR is in the G3A category, and A1 because their ACR is under 3. It pointing out that it's not being coded, and would you consider coding? Well, I think it's worth coding when they're here, and that would be for clinicians to agree with that coding. We don't automatically code things, so you'd have to agree. You might want to have a look and see, have they had 2 eGFRs under 60? I know that will only prompt if there has been. You might want to tick to say they've had an annual review. It's got the prompt saying eGFR under 60 and diabetic, consider flows in, with links to the flows in leaflet. This is the Betsy leaflet. I think it's quite a good one. Pointing out things I don't use it for the history of DKA and type 1 diabetes. Consider sick day rule leaflets. Be careful of dehydration. Be careful of thrush. I think it's quite a good leaflet. I think they overemphasize some of the lower risks, but it's useful if you do want to give patients at least the sick day rules, for example. It's got codes for adverse reactions. So say, for example, they've been started by secondary or elsewhere and stopped. It's useful to record that. Again, similar things for statin, where it's got the patient statin decision aid from NICE, which I quite like to give people, and exemption codes if you want them. Pointing out that they're diabetic with a Q-risk over 10% and no flows in, with a link to that NICE guidance on this, where we're saying, hey, we should be considering flows-ins as soon as metformin intolerability is confirmed if they have got established cardiovascular disease or Q-risk greater than 10%. And then it's got the links to things like the diabetes pathway in the community health pathway, which is useful. If you are looking at a pathway that hasn't been localized to you, it will still show you a Welsh pathway, but it may not be localized to your area. So you can see here, this is directing us to the Cardiff and Vale pathway. Cardiff and Vale have had health pathways for 5 years, have an awful lot more live pathways than the rest of Wales. It's still likely to be quite relevant to us. It's worth being aware that perhaps the request pages, the pages where it suggests what you might want to request and what and how, haven't been localized, so might not be quite right for your locality. Anyway, I'll go back to the template. Links to things like My Desmond Wales to try and encourage use of these things. And it's also got a variety of various links, so you can go to there. Any missing processes will be shown at the bottom. So, there's no foot check. That's there for us to check. They're saying there's no eye screening codes in the past year. I know screening might be too early for some, but it may be worth a review. This person, we should be considering adding to the hypertension register. We've not been great at coding that, and that's part of the cardiovascular disease QI project. It's likely this person, therefore, is on antihypertensive medication, and they're on amlodipine and ramipril. Now, ramipril could be part of diabetes and should be really. Almost everyone should be on ACE, realistically, but regardless. But amlodipine tends to suggest that there is some difficulty with managing blood pressure here. And that prompt will usually come if they have had raised blood pressures in the past. And we can see quite high blood pressures in the past. So I think worth considering coding the hypertension here, partly for monitoring and screening, but I guess it'd be up to the GPs and clinicians in the practice. This person needs their smoking status with links to help me quit. Part of the last year's QI, we want to make sure that we're ticking to say we've signposted links to that project if people still want to see that. The same for alcohol, Dan 24/7, links to them, and that's run by Kaiser Veriad, who I have a lot of time for. And then there's weight needed. We need this person's UNEs, we need their HbA1cs, and we need their lipids. The frequency of UNEs has been adjusted as per those KDIGO guidelines, like the QI asks. There'll be another video talking about perhaps how we do this recall. I wouldn't immediately bring this person in to consider a flows-in, because if they need their processes doing, I'd want their processes done before I sit them in front of a clinician. Please look at the other videos for my suggestions on how we might do that. And then at the bottom it's got that this person needs blood pressure. Diabetic Assurance Framework targets, TTO4 is 140/80, NICE is 140/90. I'm leaving both those in there for reference. So the prompts and templates align with the individuals in these searches. So I know that if you open up somebody from this Consider ACE and you open up their records, the prompt at the bottom will say Consider ACE, and the template, the cardiorenal metabolic template, would say Consider an ACE and say why. And likewise, it does the same for diabetes. So if I choose a diabetic Consider ACE, for example, you'll see that my alerts box is suggesting that we should consider an ACE, and if we hover, it'll tell me that this person's ACR is greater than 3. It'll also tell me as part of the cardiovascular and diabetes, this person needs blood pressure. It tells me the last level was 130/78, but that was 2 years ago. It tells me their target's 140/90, they have cardiovascular disease, history of raised EGFR, and a history of raised HbA1c, and history of an EGFR under 90. This box, again, the assurance concern is highlighting that, again, I'm missing a few processes. This person, HbA1c, creatinine, lipids, blood pressure, and BMI. It's always quite nice when they've had their foot check at least. If I open this one up, again, it's emphasizing this person is eligible for a statin. Their Q risk is significantly over 10% and over 20%. They don't have any previous contraindication codes. It's not impossible that they have declined in the past, but we've not been so good at coding these things. Pointing out cholesterol over 4, it's suggesting coding for CKD. This person, G2, A2, not all G1s and A2s do need coding, but I think if there's an A2 where their ACR is over 3, we would, because they're into the moderate risk territory, I would be coding that there. This is an interesting aside. We have put in a frailty coding box if their EFI is likely to be greater than 0.12, which considers at least mild frailty. Now, we can't just code because the EFI, the ask for the contract is at their annual reviews or clinical reviews that we do the Rockwood scale. So there's a link to the Rockwood scale. I know this person is more like a Rockwood 2 to 3. I don't think they do much more than routine walking, so they probably are closer to 3, but they're certainly not in any real frailty here, so I wouldn't be coding even a mild, moderate or severe frail. It's useful to code them as mild, moderate, or severe because that would then be coded in their records and visible for people like out of hours and any other users as a problem in their problem list. If you do a referral to WCCG and you've coded them here as a problem, it will be visible to the receiving clinician, which is very useful for them too. Pointing out this person's diabetic, raised ACR but no ACE, and no previous contraindication codes. It's pointing out that their Q risk is likely over 10%, no statin, and then the diabetic annual review box, please tick. I know lots of mine are getting reviewed and they're not ticking the annual review, so this is something we want to re-emphasize and re-push for this year's QI. I appreciate that diabetes isn't necessarily the focus of this year's QI, but again, the overlap between diabetes and CKD in the groups we're looking at here is huge, and I think it's very useful to focus on both, and partly why we're sharing processes, prompts and templates to look at both. Links to the various things here, and then we've got the missing processes at the bottom. So if your HCAs or phlebotomists are using this, they might want to go down there. It's not the same as the full HCA template that we've got that shows you exactly what processes are missing for everything and anything in one place. If people are interested in that, please come and contact me. Now, there are a couple of other slightly useful parts in the prompts and templates, and they relate to perhaps identifying patients where we should be considering early referral to the renal team. The guidance is quite good at advising how to manage most of our CKD patients, with an emphasis on things like blood pressure control, statins, flozins, ACE inhibitors, and modifying risk factors, lifestyle. We know that that is going to be the mainstay of treatment for most of our CKD patients. But it's also pointing out the ones that we might need to refer for further advice. So when we're looking, for example, we want to identify if there's patients with sustained drop of EGFR of more than 25% and a change of EGFR category as in they become EGFR under 60 usually there, or a decrease of 15 mils over the past year, and then things like ACRs over 70, and this other thing, the KFRE score greater than 5%. Now, we can't give people medical calculators, but we can have the prompts highlight when people perhaps are at risk. So, for example, in this patient here, you'd see a thing saying CKD concern. And when I hover over the box, it's telling me that the 4-variable kidney failure risk score is likely greater than 5% here. It's telling me that the EGFR drop is greater than 15 and more than 25% in the past year. If I open up the template, it should also give me those prompts. So again, you'll see that it's recommending that we should be considering a statin. EGFR under 60 really should be. Q risk higher than 10-20% we should be. It's interesting because I know this person very well, and I know that they've declined them, but we've not been good at coding. Their cholesterol's over 4. They are in a very high risk group because of their EGFR, particularly their ACR. ACR is what's really a concern here. And we can code that if they are very high risk. I think we should be doing or considering doing KFRE scores there as per NICE and as per the health pathway. It talks about the flows and indications, and it's pointing out greater than 15, greater than 25, and it gives you a link to the 4-variable kidney failure risk equation calculator. It'll do this if it thinks in the background this person is likely greater than 5%. You may want to consider doing it for everyone who is coded as very high risk. If I go to this calculator here, so if I go back to that box and click on the link, you'll need to remember their age, gender, EGFR and ACR. So I would go here and say, there we go, it's EGFR 40. ACR was 65, I think, or something along that line. And if I submit that in, it will give me the score. And you can see that their 5-year KFRE risk is greater than 5%. And it's a little bit of a safety net. I guess it may be sensible to consider doing KFRE as part of the review for everyone in the very high risk groups, so particularly those with high ACRs in the high risk group. It sort of gives you all sorts of other bells and whistles. So this person's on insulin. We really should be recording that they've had advice about driving with links to advice on driving. I know that we often give these leaflets, but if we don't tick the box, we can't demonstrate that we've done this. And I think we do need to go back to a culture, make sure we record these things better. Links to sick day rules, hypoglycemia, the diabetic review, and then if we keep going, it's the foot checks, the hypertension review, and then the lifestyle issues, and then the processes that are missing for this person. It's difficult to show absolutely everything in a relatively short 20-minute video. Most of these things you'll see over time. You will get alerts and prompts. For example, if it's suggesting we should consider finerenone, although it's important to maximise ACE first before referring, of course. And it's got all sorts of bells and whistles in there that can be very useful. So, for example, in stroke patients, it'll highlight if they haven't been anticoagulated, and a template will give you advice on how to CHAD score. And it's trying to cover all the things that cardio-renal metabolic issues would flag up here. It's not the same as the bigger HCA and chronic disease templates and prompts that we have created that cover absolutely everything, partly because that's quite overwhelming and needs a lot more installing by us. I will be creating videos on how to install these templates and searches, and also a video looking at perhaps how to look at catch-up and how to perhaps look at recall for these groups.